Good afternoon. As he said, I'm Dr. Amanda Schockel, and I am excited to introduce our third session today of our 2023 mid-year seminar. We'll be discussing anesthesia emergencies. For this session, we're going to hear from Drs. Raymond, Miraverti, and Rossi. We're going to first start with Dr. Raymond. Dr. Raymond is an assistant professor of anesthesiology at the Vanderbilt University Medical Center in Nashville. She is fellowship trained in obstetric anesthesiology and currently serves as the obstetric anesthesiology fellowship director at Vanderbilt, as well as the director for in utero fetal surgery. In addition to caring for high-risk obstetric patients, Dr. Raymond also carries a passion for perioperative medicine and optimization prior to surgery. Her research focuses on enhanced recovery after surgery programs, and she is currently leading a large-scale pragmatic trial on the impact of perioperative ketamine. Dr. Raymond today will be speaking on obstetric emergencies. If you would all like to join me in welcoming Dr. Raymond here to the podium. Thank you.
Thank you, everyone, and thank you, Dr. Shackle. Unfortunately, I have no financial disclosures. And in preparing for this talk, I was told to speak on obstetric emergencies. There is a plethora that came to my mind, but given the 30-minute time limit, I have narrowed it down to 4. So today, we're going to be exploring what nuances are there in ACLS when your patient is pregnant, what differences are there in the resuscitation of a massive hemorrhage, is there a plausible mechanism to treat amniotic fluid embolism, and lastly, developing an algorithm to treat high block. So first, we're going to start out by looking at the scope of the issue. So since the early 2000s, the maternal mortality rate in the US has been on the rise exponentially. That's due to a variety of different factors. True, we are getting better at reporting it. It wasn't until 2003 that death due to a maternal cause even was on a death certificate. However, the acuity of the pregnant population is changing. Women are developing pregnancies later in life and coming to our care with morbid obesity, cardiovascular conditions. And while we may be thankful for the advancements in fertility treatments, it often supports multiple gestation, which is a higher risk pregnancy, and even supports pregnancy in patients that were considered too high risk initially. So the point of this slide is basically to implore you as anesthesiologists, you should be prepared and expect to see an increase in the amount of emergencies and adverse events on L&D. Even more so, as an anesthesiologist, you have the tools, the knowledge, and the expertise to make a difference in the maternal mortality outcomes. You are an expert in resuscitation and physiology. So let's start with our first topic, which is ACLS in pregnancy. Now, if you had to guess, you probably would think that hemorrhage is up there in terms of etiologies, and of course it is. Yes, women are hypercoagulable in pregnancy, but they're also prone to going into DIC. I feel like if you even just give the side eye to a pregnant woman, she's in DIC right away. But of the leading causes, amniotic fluid embolism is actually the most specific, and we'll talk about that in a few minutes. And if a cardiac arrest occurs in your pregnant patient, I want you to take heart. That is a pun that I have intended. So take heart, because unlike the dismal outcomes that are associated with in-hospital cardiac arrest, your heroic efforts are likely to lead to a positive outcome for this woman and her child. And although maternal cardiac arrest is rare, depending upon the volume of the center that you practice, you will probably encounter it every 2 to 3 years. And if and when it does occur, you have to remember there are nuances for ACLS in pregnancy. Most important is going to be left uterine displacement. These are images from one of my favorite studies that was done in Japan, because that is the only country in the world that a 9-month term pregnant woman can fit in an MRI scanner. Okay, but basically what the authors are looking at here is the degree of aortocaval compression in women compared to the degree of tilt. And so you can see when a woman is supine, that IVC is obliterated. She is completely dependent upon collaterals to get blood back to her heart. Collaterals meaning your epidural veins, your azygos vein. That's why epidural veins are so huge in pregnancy. At 15-degree tilt, the IVC kind of squeaks open, but it's really not until a full 30-degree tilt that that IVC is actually contributing back to venous return to the heart. As you might imagine, performing chest compressions at a 30-degree tilt is a little challenging. And in fact, research would actually support you that your chest compressions are going to be ineffective. Alternatively, you should assign someone specifically to left uterine displacement. Depending upon where they stand, it is acceptable to either pull the uterus towards you or to push it away. Either one works. And depending upon when you trained, you may be familiar with old recommendations where they suggested that you place the hands higher on the sternum to account for that cardiac rotation in pregnancy. That is no longer the case. That is not supported by evidence. Please place your hands normally as you would on the sternum. You may not be aware, but the American Heart Association actually has an ACLS algorithm that is specific for pregnancy, and we're going to walk through it together. So imagine that a maternal code is called and you present to the floor. The great news is most of ACLS is the same. You do not have to account for her increased volume of distribution. The drug dosages are the same. The timing is the same. Defibrillation is safe in pregnancy. Just as you would place the hands normally on the sternum, the pad placement is also the same. So thankfully, a lot of things don't need to be accounted for. However, as more people arrive to the room, that's when you're going to start to divide and conquer. You're going to have one team that is really dedicated to continuing the ACLS algorithm and another team that's focused on the obstetric nuances. So we'll start with ACLS because that's the easiest that we all know. Pretty much the same, except in this particular scenario, it is recommended to establish IV access in the upper extremities or neck. That way you can completely avoid the aortocaval compression. And unlike the traditional ACLS algorithm, there is a recommendation to administer calcium because these women often are on magnesium either for fetal neuroprotection or for preeclampsia. So let's get to the OB side of things. It's important to remember that everything that you do for this pregnant woman, your action is for her benefit, not the baby. In fact, detach those fetal monitors, okay? So yes, you perform the left uterine displacement, and this team is getting prepared to perform what we call a perimortem cesarean by 5 minutes. I do believe that the term perimortem cesarean is misleading because it gives you the idea that, well, if mom's already dead, let's at least deliver fetus and give it a chance. That's actually completely opposite of what you're trying to do. And in fact, Dr. Chestnut will suggest that we reterm perimortem cesarean to be a resuscitative hysterotomy. The point of delivering the fetus is for the mom's benefit, not for the child. That means you do deliver even if that fetus is not term or not even viable. If it's at 20 weeks, you still deliver. The point is you're trying to alleviate aortocaval compression completely and at least give the mom a shot at having cardiac output return to her heart. When the perimortem cesarean occurs, you want to do it at the location of the cardiac arrest. Do not waste time going to the operating room. Do not waste time looking for uterotonics, looking for equipment. You don't even need skin prep. All you need is a scalpel. And this box I added myself. This is actually not part of the ACLS algorithm. But based upon my experience, the times that I have been in this scenario, after the perimortem cesarean occurs, these women bleed profusely. Obviously, there's no surgical control of bleeding. There's often no urotonics. Your ACLS cart doesn't usually come with that. You're sending someone out to go get them. But even more so, they tend to go into DIC very quickly. And so I added my own box here that I would recommend that you do not forget to ask for your tonics and go ahead and activate your MTP. It's okay if you don't need it, you can always cancel it, but I would advise that you go ahead and activate. And speaking of MTP, I'm going to discuss hemorrhage briefly. I recognize that the presentation after this is on massive transfusion, but given that hemorrhage is the #1 killer of pregnant women worldwide, I feel like I have to touch on it a little bit, so I'll give one slide. When you define it, back when I trained, the definition of postpartum hemorrhage was different based upon the mode of delivery, cesarean versus vaginal. However, that is no longer the case. ACOG now defines a postpartum hemorrhage as 1,000 cc of blood loss, regardless of the mode of delivery. When a hemorrhage occurs, you have to be thinking about the etiology, otherwise it won't stop. I use the 4 T's, I think it's the easiest. So when I'm in a hemorrhage scenario, I'm thinking, does she not have any uterine tone? Are there retained products of conception, tissue? Is there placenta that's still in the uterus? Is there a trauma? Is there a cervical laceration that we're not seeing? Or lastly, is she developing coagulopathy? And like I said, DIC is very common in pregnancy. The placenta is one of those organs that releases tissue factor, which can stimulate DIC. So there are a couple nuances that are different that probably won't get talked about in your next presentation. When you encounter a postpartum hemorrhage, you absolutely should be giving TXA as soon as a hemorrhage is identified. At my institution, as soon as we hit 1,000 cc's of EBL, we give it. If you're interested in the literature that supports this, the Woman trial is considered the landmark article that supports this practice. And in addition, if you do not have an OB-specific MTP at your institution, you should get on it right now. Massive transfusion in pregnancy is focused on re-establishing fibrinogen because women, when they bleed, the fibrinogen drops precipitously. And fibrinogen on average in a pregnant woman is around 500 or so. So if you get your labs and it says 250, that is a problem. She is in DIC. And the quickest way to restore that is to give her either cryoprecipitate or to give her fibrinogen concentrate. So at my institution, because it takes time for our cryo to thaw, the cryo will come with every other cooler. So we do have a specific MTP for OB. Additionally, because mortality and morbidity is so high with hemorrhage, the Department of Health and Human Services partnered with ACOG to come up with what they call maternal safety bundles. And the AIM, I forget what it stands for, I think it's Alliance for Innovation in Maternal Health, has these bundles available for everyone. And when it comes to the postpartum hemorrhage bundle, there are 3 things that they advise every L&D unit should have. Number 1, a hemorrhage cart. Number 2, a response team that is dedicated for postpartum hemorrhage. And number 3, a postpartum hemorrhage checklist. And they actually have an example for you to download and utilize at your institution today. So just by having a checklist, it's going to decrease the amount of transfusions that occur, decreases the need for hysterectomy, and decreases the development of DIC by 60%. This is my little soapbox here because antibiotic stewardship is also an interest of mine. Don't forget that if you are in a peripartum hemorrhage, like let's say a C-section for example, you have to redose your antibiotics every 1,500 blood loss. So sepsis is now the number 2 killer of pregnant women in the United States. So that's my little soapbox announcement for that. Moving on to my favorite topic, due to the physiology involved, amniotic fluid embolism. So typically, traditionally, you think about it during labor, but it has been recorded and documented to have occurred up to several days postpartum. So still think about it if you're responding to a maternal code. Initially, it presents with either like acute dyspnea or acute altered mental status or agitation. The times that I have seen it, it usually presents with what is described as brief seizure-like activity and like this posturing that quickly goes into cardiovascular collapse followed by DIC and hemorrhage. Now the physiology I think is incredible, but basically you could summarize it as a pulmonary hypertension spiral. And the term embolism is kind of a misnomer because it's not actually a blockage of blood flow at all. But what happens is, as the amniotic fluid enters the maternal pulmonary circulation, inflammatory markers cause this intense vasoconstriction. And that vasoconstriction gets so tight that platelets aggregate. And when they do, they get activated, releasing thromboxane and serotonin, which are very potent local vasoconstrictors. That then feeds back to the pulmonary circulation, causing a pulmonary hypertension spiral. The ultimate manifestation of that is going to be acute right heart failure. Sometimes, as that RV dilates, the septum bows into the left heart, then causing left heart failure. However, what you may not be aware of is the contribution of a vagal response. So half of your vagal receptors in your heart and your lung is serotonergic, not cholinergic. And this vagal response is so strong that these women will get either progressively bradycardic down to asystole or just go right into asystole because of it. And the importance of the serotonin response is so strong that if you look at animal models, if the research team doing the AFE animal model, if they did a vagotomy prior to inducing an AFE, it prevented circulatory collapse. It didn't prevent the pulmonary hypertension, but it prevented cardiovascular collapse, and that's how important this vagal response is. In terms of treatment, not much, you guys. It's pretty much supportive. However, I will say that if and when you see an AFE, I want you to be thinking that everything is going to be A-OK. So if we go back to the etiology, as an anesthesiologist, you have at your disposal regular medications that can treat each one of these mechanisms. You've got atropine to prevent that vagal response. You also have an anti-serotonergic medication called Zofran. That not only works at the serotonin causing the pulmonary vasoconstriction, but it also prevents the vagal response. And you also have a medication that directly inhibits thromboxane. So everything you have is A-OK. Does this work? Well, it certainly works in animal models. The first utilization of it in human models was 2013 with Dr. Layton. She describes having 40 minutes of asystole and cardiac arrest. She knew about the animal models and was involved in that research, so they decided, what the heck, it's been 40 minutes, why don't we try it anyway? She had ROSC within 2 minutes. Looking at other case reports in humans, if you look at the vitals that they published for their patients, you will see the patient is flatlined, and within 5 to 7 minutes of administering A-OK, they get ROSC. So does it work? It certainly has in the past. I would argue it certainly doesn't hurt. If your woman is already in asystolic arrest, I don't think giving her Zofran is going to be her downfall, right? And I'll tell you, I still to this day remember an AFE when I was training, and when we suggested, hey, can we try A-OK? The attending was not familiar with it, and so we didn't do it. And to this day, I still think about what might have happened had we tried. So is it currently recommended by ASA or ACOG? No. We don't have the literature to support it, but I will say it's very hard to do prospective studies for an outcome that is so incredibly rare. You can't really randomize people to this. And it's hard to get permission to do research in pregnant women anyway. So all we have are these animal models. I don't know if we're ever going to get official stance on whether or not A-OK should be given. There's other items that are out in the literature, such as intralipid, showing some benefit. So stay tuned. We may have a plausible etiology, or rather a plausible treatment for the etiology. Lastly, high block. This is one of the most common obstetric anesthesia complications. For some reason in Europe, specifically in the UK, that last PubMed ID, the number one cause of cardiac arrest in their women was actually a high block. That differs from the US, so I'd be interested to talk to someone who's practiced over there. But basically, it usually is one of two things. You either have an unrecognized intrathecal catheter, or someone placed a spinal after a failed epidural top-up. So it was ingrained in me so much to never do a spinal after you top up an epidural that I actually thought that this was Not everybody knew this, but apparently not, because it even happens at my institution about once a year. If you top up an epidural and try and put volume in that epidural space, you expand it, which then compresses your intrathecal sac. So any medication that you administer is going to go much more cephalad than you intended. You should never, never, never place a spinal after you have topped up an epidural. If you have a trainee and they get asked that on their oral boards, they will not pass, okay? In terms of clinical course, typically starts with hypotension. As it starts to rise and you get the accessory muscles, they're going to start complaining of difficulty breathing. Eventually, it's going to get up to C3, 4, 5, and then they're actually not going to have a diaphragm that's working for them. Ultimately, a total spinal, they're going to lose consciousness. If you are wondering, is this from hypoperfusion of the brain or a direct effect of the local anesthetic, take a look at their pupils. The local anesthetic is going to prohibit the cranial nerves from causing any pupil constriction. So if you see pupil dilation, you know you probably have a total spinal. Ultimately, if you don't take care of it, it will progress into unopposed vagal tone, which can lead to cardiac arrest, hypoxemia if you don't secure the airway, or just continued hemodynamic instability. How do you manage it? First, if you're in obstetrics, you're probably utilizing a hyperbaric solution. So go ahead and put your patient in reverse Trendelenburg. Unfortunately, when you do that, you kind of shoot yourself in the foot here because now all of your cardiac venous return is pooling in the legs. But if you're trying to prohibit the spread, that is one thing that you can do. Second, go ahead and treat that vagal response. Atropine, again, is going to be your friend, or ephedrine, and treat the hemodynamic instability. You're going to want to pick a vasoactive drug that has some beta activity. You want to support the heart. So epinephrine is going to be your go-to. And there are some authors that at this point in time, if you're having such difficulty controlling her hemodynamics, they actually say, go ahead and put her in Trendelenburg. Sure, your block is going to be higher, but at least you're getting that cardiac output return, and then go ahead and intubate. Speaking of which, when you do, please do an RSI. These women are considered full stomach after 20 weeks. And please use an induction agent. So women who have undergone a total or high spinal will tell you that they can hear what's going on, they are aware of what's happening, and they're panicking. So when this has happened to patients that I've been involved in, I'm the one that's putting the oxygen mask on the patient while I'm asking my trainee to drop drugs and get my tube ready. I'm talking in her ear and I'm saying, I recognize that you're having trouble breathing. I'm sorry that this is so scary. I'm taking care of it. I'm going to give you medications, etc., because she will remember. And speaking of that, go ahead and provide sedation, because after you've given her paralysis, you want to continue to provide sedation until that block wears off. Things that let you know that's resolving, you're starting to get your hemodynamics back, or she starts breathing spontaneously. And lastly, if you've ever been involved in a total or high spinal, it is absolutely chaotic. You're trying to do multiple things at once. You're trying to treat her hemodynamics. You're trying to prepare for intubation. Everyone's screaming. Lots of things are going on. But there is no need to make it more complicated on yourself. The obstetricians do not have to do an emergency cesarean delivery. If the fetal heart rate is normal, don't let them do anything. Take care of mom, get things settled, get her stable, and then they can proceed with a cesarean in an elective fashion. Best treatment is going to be prevention. So, never perform a spinal after a failed epidural. I always crack the head of my bed, so even if I tilt the woman in Trendelenburg trying to get my block to rise, I always crack the neck at C7, so that way it won't go against gravity and go any higher than C7, hopefully. Beware of obese patients. They are at the highest risk. Literature supports that when you place a lumbar epidural in an obese woman, you tend to be placing it higher than you anticipate. So you may think that you're at L4, L5, but you're actually at 2, 3. And they have higher intra-abdominal pressure. So due to the obesity, or whether it's polyhydramnios or twins, multiple gestation, anything that puts pressure in the abdomen is going to do that same thing that we talked about when you put volume in the epidural space. Compresses the intrathecal sac, pushes the CSF upward, and you get much higher cephalad spread. And lastly, no factors that are related to spread. So much more than volume, dose is actually the most important aspect of what tells you how high your block is going to go. They've done studies where they have compared giving the same dose of local anesthetic at different volumes. I'm making this up, but let's say they gave 10 milligrams of bupivacaine for 1 cc and 10 milligrams in 2 cc's, and they get the exact same level. So it's more of a dose than it is a volume. Position of the patient. So some people practice where after they place a spinal, they have the woman sitting up for several minutes. Literature actually shows that it doesn't necessarily matter for a few minutes if you lay that woman down immediately or delay it, because the CSF flow and the medication is going to continue to move and disperse for about 20 minutes. Eventually, even though the block is lower, if you delayed her laying down, given enough time, it's going to reach the same exact level than if you laid her down immediately. The only difference being, if you lay her down immediately, they often get more hypotension, tachycardia, that sort of thing. And then lastly, CSF volume, which is basically a surrogate for me saying intra-abdominal pressure. So this was a study where they looked at patient-related factors in terms of administering a hyperbaric solution into the intrathecal space. You will see height did not matter. So I know it's common practice to be like, oh, how tall is she? And that kind of goes into how much dose you want to give. The reason height doesn't matter is because the difference between a 5'2" woman versus a 5'8" is actually not the neuraxial spine. It's a difference in the length of her extremities. So normally, the axial spine is a consistent length, usually in the adult human. So you can see vertebral column length actually did play a role, but not necessarily height. And neither did weight or BMI or how much weight she gained. It was actually the abdominal girth that we talked about. And then AFI or amniotic fluid index also being a surrogate for the abdominal girth. Lastly, this is just something that if you wanted to take a picture of, it's a nice article that kind of summarizes the factors that go into how high your block goes. Like we talked about, most important is going to be the dose. Also, if this is hyperbaric versus isobaric. In terms of patient factors, the CSF volume, again, that is a surrogate for basically intra-abdominal pressure. And then patients that are more sensitive to local anesthetics, which includes pregnancy and elderly. And then procedure factors, what position you have them when you place it, for example, if you're doing isobaric, which side you have up. And then epidural injection post-spinal. So I know that I've harped on never do a spinal after topping up an epidural. The reverse is also true. So if you're placing a CSE, and you have a nice, T4 level, let's say she's starting to complain of pain, you go ahead and give your test dose before you top up. Well, even that test dose can actually cause your level to rise, and I've seen that several times. So that is all I have for obstetric emergencies. Thank you all so much for your attention, and I believe questions are going to be at the end. I guess I'll just summarize maybe, I don't know. We talked about cardiac arrest, important things, left uterine displacement, prepare for perimortem cesarean at 5 minutes. Postpartum hemorrhage, don't forget TXA and cryo. AFE, try AOK. And for high block, just know your risk factors.
Thank you so much, Dr. Raymond, for your expertise. We're going to have a nice segue now into massive transfusion protocols and trauma. So I'd like to invite Dr. Miravati to the podium. Dr. Miravati is a pediatric anesthesiologist at the Children's Hospital and Medical Center in Omaha, Nebraska. She is an assistant professor of anesthesiology at the University of Nebraska Medical Center. She completed her medical school at the University of Arizona College of Medicine in Phoenix, and then proceeded to do her training at the University of Nebraska Medical Center, and then has continued her training there at the Nebraska Children's Hospital and completed a pediatric fellowship. Please join me in welcoming Dr. Miravati.
All right, I can actually see over the podium. Interesting. All right, so my name is Myrene. I'm one of the pediatric anesthesiologists in Nebraska, so in Omaha. And while I love working with kids, it does come with risks, including a cold. And so I am recovering from one. I'm fine. I think everybody is going to be fine, but just bear with me if the voice is a little abnormal today. But The topic we're going to be discussing is big, and so it was really hard to fit everything in a 30-minute talk. And so a lot of the points that I'll be making are very high level, and hopefully we'll make some salient points, and then if there's any questions later, we can expand on this. So this is massive transfusion in the setting of trauma. I also don't have any disclosures to give, unfortunately for me, I guess. And then as far as learning objectives, so briefly we'll go over some background information and try to define what massive transfusion means. And then after that, we'll try to identify which patients would benefit the most from receiving a massive transfusion in the setting of trauma. And then lastly, describe the major components that would consist or make up a massive transfusion protocol. So it's been well documented, and we all know that hemorrhage is a major cause of mortality in trauma patients, and obviously would contribute to early death if it's not addressed immediately. And so we address that by initiating rapid resuscitation, and this is crucial to the patient's survival. And our goal is to maintain perfusion and oxygenation, and also to mitigate the trauma-induced coagulopathy, which can worsen with inadequate resuscitation. Ultimately, the goal is to get this patient to where they can be addressed and get to hemostasis, and that's usually by means of surgical intervention or embolization. However, it is necessary to stabilize them first before we can even consider that as an option. And so all this to mean that adequate resuscitation is just as important as the surgical intervention itself. This is a very simplistic diagram that just shows what we're dealing with in a trauma patient in the setting of hemorrhage and all the different factors that contribute to coagulopathy and bleeding. And so if we have a patient with severe injuries and they're experiencing hemorrhaging, of course there's loss of blood volume and they experience hypovolemia. I think the mouse works. Okay, here we go. Hypovolemia, and then that leads to hypoperfusion of tissues leading to hypoxia and then acidosis, and this contributes to coagulopathy and worse bleeding. And then to address the bleeding, of course, we do our best and we try to perform a resuscitation, and that involves both fluids and blood products. And the administration of those will then would lead to hypothermia and hemodilution, both of which contribute again to worsening this coagulopathy state and bleeding, and ultimately leading to death. And so the loss of circulating blood volume and the development of coagulopathy are the major contributors leading to the death of the patient. We know that coagulopathy is multifactorial, and beyond the trauma triad, there is also this separate entity called ETIC, and that stands for early trauma-induced coagulopathy. And this is a disturbance in both coagulation and fibrinolysis that is immediately present after that initial injury. And so it's actually not thought to be related to the resuscitation efforts at all, but rather something that happens independent of that. And the presence of ETIC is a predictor of mortality. The mechanism behind this entity is not completely understood. There's two prevailing theories. The first one is a development of a DIC-like picture, and this is due to hyperactivation of the coagulation pathway via the activation of the extrinsic pathway. There's an impairment of the anticoagulation system, as well as alterations in fibrinolysis that all favor more bleeding. And then the second theory that has been describes hypoperfusion leading to the activation of protein C and an increased plasmin formation leading to hyperfibrinolysis. So again, promoting more bleeding and eventually, unfortunately, the patient's demise. And as an early finding, if labs were obtained in these patients, what you would find is an elevation in PT and PTT level, and if a TEG was drawn, there'd also be some abnormalities there. And again, this is found before massive hemorrhage or even extensive resuscitation has been performed. All right, and so to describe the more traditional factors that contribute to the coagulopathy, we know that hemodilution is bad, so is hypothermia, and so is acidosis. With blood loss, of course, there's loss of cellular components as well as coagulation factors, and with resuscitation, especially if that is not balanced, it can lead to even worse dilution of that and promote bleeding. And so definitely important to avoid worsening the dilution of the patient's blood. And then avoiding hypothermia is essential because we know that hypothermia, the enzymes involved in the coagulation cascade are temperature sensitive, and so this affects clot formation and then also increases clot degradation. And then hypothermia has a direct effect on platelet function, and so this affects their ability to be activated and aggregate and form that strong clot. Acidosis also is an issue, of course, because it impairs enzyme activity and it prolongs the initial formation of clot, and whatever clot does form has poor strength, and so it's prone to degradation and, of course, worsening bleeding. All right, so now, of course, we know that this patient now needs to be resuscitated, so we discussed that part of that would be the transfusion of blood products. And I think the interesting thing on all of the reading that I've done is that there really isn't a universal consensus on what massive transfusion means. I think it's understood that obviously it involves giving a lot of blood products, but like how much exactly? And in the traditional sense, a lot of studies have described massive transfusion as giving at least 10 units of red blood cells over the initial 24 hours of the patient's presentation, but this is a very limited definition. It's purely volume-based. It's prone to survival bias because, well, frankly, not everyone makes it to 24 hours, and if they didn't get the 10 units, does that mean that they weren't massively transfused? It's just hard to apply universally. And then it also doesn't take into account the severity of bleeding, and so I think by and large, by this point, we can consider this to be an obsolete definition. Later studies also apply more of a volume-based definition for massive transfusion, and these three here really I've taken from various studies. It just shows that there are different ways to describe massive transfusion amongst different institutions, but again, a volume-based definition still isn't really reflective of what we're trying to describe. And so there have been other ways to describe this massive transfusion concept, and one of them was introduced by the PROMPT study, which stands for Prospective Observational Multi-Center Major Trauma Transfusion. And resuscitation intensity essentially looks at how much units of resuscitation fluid does a patient require in their initial 30 minutes for some sort of stabilization. And they're pretty broad in what they describe as a resuscitation fluid. So that includes crystalloid colloids, red cells, FFP, and plasma. And what they found is the more intense the resuscitation needed, the patients had a higher mortality. So they described it as greater than 3 units of resuscitation fluid in that initial 30 minutes was a predictor of severe hemorrhage and death. And then this is another more modern concept defining massive transfusion. It's called CAT, or the Critical Administration Threshold, and it assesses hemorrhage severity based on the transfusion rate. It's been found to be a more reliable predictor of mortality compared to other definitions that have been used in the past. And a patient is determined to be CAT positive if they've needed 3 or more units of blood products within any 1 hour period in their first 24 hours of presentation post-injury. And the patients that are CAT positive have a 4 times higher risk of mortality compared to patients that were CAT negative. And amongst the patients that were CAT positive, if they presented with that positive score earlier on in their admission, or if they had multiple episodes of being CAT positive, those patients had an even higher risk of death. Moving on, now we know what massive transfusion is globally, but the next thing to do is to identify which patients would actually benefit from this intervention. And so the reason for prompt identification of which patients would need this is because we know that survival is dependent on how quickly this resuscitation can take place. And so many authors and institutions have attempted to find a way to predict which patients would need massive transfusion, and they've developed a number of different scoring systems. These are all based on different variables, and that includes clinical parameters, lab values, imaging results, and then other physiologic factors. And there are a lot of them out there. I'm only going to describe 2 that are most commonly used, but essentially my point is the less complicated and the less reliant on labs that the testing or the scoring system is, the more clinically useful it'll be. And I'll describe one of each essentially. And so the first one to discuss is the ABC score, and that stands for Assessment of Blood Consumption. And this is actually a nice tool. It's simple, it's easy to use, and it's been validated in the trauma setting. And it is recommended by the American College of Surgeons to be used as a trigger for initiation of massive transfusion. It's only based on 4 variables, and they're assigned 1 point each on this system. And so if the patient has a penetrating mechanism of trauma, a positive FAST exam, low blood pressure with a systolic less than 90, and then an elevated heart rate with rate greater than 120 beats per minute, the patient would be assigned a point for each of those. And then if their score is greater than 2, then that would predict the need for massive transfusion and should be a trigger to initiate that protocol. The beauty of the simplicity of this tool is that you can easily recognize all of these variables on your primary survey. There's no wait time, there's no need for labs to result, there's no complex calculations. And so if MTP does need to be activated, there is no delay in doing so and being able to recognize that this patient is going to be needing this. The TASH score is a more comprehensive tool, although it does have its own limitations. And while it can have excellent research value, it's harder to use in the acute clinical setting, only because you are needing more variables to be able to calculate the final score that will lend you to be able to make a decision. And so the variables include blood pressure, heart rate, hemoglobin, and base excess, which have to be drawn, the patient's gender, and then also presence of fluid on a FAST exam, and then the presence of fracture in either lung bones or the pelvis. And so each of these variables are assigned weight-based values up to a total point number of 28. And then you use that number to calculate a TASH score. And if the score is 16 or higher, then the patient has a 50% chance of requiring massive transfusion. So nice to be able to calculate the probability, but the problem is it takes time for everything to result. And by the point that your labs have come back, I think you would have gone past the point of when you should have initiated the massive transfusion. So less helpful for this patient, and you're wasting precious time. So in addition to the scoring systems, there are other considerations that can be put to mind when trying to determine which patients are going to need massive transfusion. And so you're looking at the patient and their overall clinical picture. Are you assessing for persistent hemodynamic instability? Are they actively bleeding and potentially will need embolization or surgery? Is there a requirement for blood transfusion immediately upon arrival or even before they've reached the trauma bay? And the use of uncrossed blood to start the resuscitation is actually in itself a trigger to start massive transfusion protocols. And then if labs are available, severe abnormalities like acidosis with a pH less than 7.25, a large base deficit, severe anemia, or any tag abnormalities could also serve as a trigger for transfusion. What isn't a good trigger for transfusion is clinical gestalt alone. That's a poor method. It's been shown that clinicians had a tendency to overcall the initiation of massive transfusion, but also somehow miss some patients that would have needed it. And so that's why these scoring tools, or scoring systems, were developed as tools, as well as using that in combination to the other triggers that we've discussed here. Your patient was involved in a trauma, they're bleeding, you've identified that they need massive transfusion, so how do you do it? Well, massive transfusion protocols have been found to be the most helpful in getting or decreasing that time to transfusion from injury. And as we previously discussed, decreasing that time is the most essential to improving mortality and improving patients' outcomes. So with a protocol in place, you're able to facilitate coordination of care, and that helps prevent delays in initiating that transfusion. There's a lot of people and departments involved in having a successful protocol, and so that includes work between the trauma bay, the emergency department, transport team, the blood bank, nursing staff, laboratory, as well as OR and OR personnel if a surgical intervention is going to be needed. A protocol will help streamline the processing and administration of large amounts of blood products, and then again minimizes time between injury and intervention. And the patients that have benefited from early activation of massive transfusion have been shown to have faster time to hemostasis. They have lower rates of morbidity and mortality, shorter total hospital duration stay, and then also decreased amount of blood products that were transfused overall. And so obviously the benefits of having a protocol in place are evident here. All right, and so these are the major components of what would make up a massive transfusion protocol. We've already talked about the triggers, and so again, having that scoring system, and then the patient's presentation would be the primary triggers that we discussed. So we'll move on to discussing the other parts. And so a protocol should describe should have a way for product to be immediately available, and then also a way for more to be processed so the patient can get this transfusion. There also needs to be a way to deliver the blood products in an efficient manner. And then lastly, knowing what are you actually administering. And then a protocol should also have some considerations for when to use adjunct medications. And then lastly, we need to know when to terminate the protocol, because this cannot be just an indefinite intervention. All right, so once the protocol is activated, the first step that needs to happen is to promptly notify the blood bank and lab, because we need to start planning for getting those blood products to the patient. And that does involve initial lab draws to make sure that we send cross-matched units for the patient. But of course, we know that it's not always possible to do that immediately. So one important component of an MTP is having emergency release products in the trauma bay and in the emergency department that can be used to start the transfusion while you're waiting for those cross-matched units. And the emergency release products should consist of universally compatible blood products, and that would involve type O red blood cells, and then thawed AB or A-type plasma, which should be usable for these patients until their cross-match products are there. And then aside for sending or for having those products available for the patient, it needs to be delivered to them. And so protocols have described having a dedicated runner, meaning literally a person whose only job is to get these products from blood bank to the patient. And they usually come in the form of a cooler that has the components that have been designated for them. And the ratio that's been most supported in all of the literature is the 1-to-1-to-1 ratio of red cells, FFP, and platelets. And then, as described earlier, cryoprecipitate doesn't necessarily come with every single pack. Usually it's every second, and that also can vary depending on the institution. And so I think we do need to talk about the rationale for why this ratio is what's used most commonly for trauma centers. And this is because both military and civilian trauma studies have demonstrated that the patients that have been resuscitated with higher ratios of FFP to RBCs are the ones that have demonstrated improved survival. And this is in comparison to patients that received low ratio transfusions. And then if the transfusion in this ratio is given early, meaning within 6 hours, those patients had improved survival rates as well. And just kind of simplifying things, I mean, if you think about it, when there's a situation of hemorrhage, you're losing whole blood. And so this 1-to-1-to-1 ratio mimics what the patient is losing. And so it is addressing the loss of cellular components. It's also addressing the loss of factors. And your goal is to try to restore oxygen capacity, oxygen carrying capacity, and intravascular volume, and replete cellular components as well as coagulation factors. So this ratio addresses all of those needs. And then these are some of the landmark studies that have described and supported this 1-to-1-to-1 ratio. And of course, there's more, but these are the ones that have essentially started or paved the way for this type of rationale. Okay, so then moving on, the MTP also should have some considerations for when it would be appropriate to use adjunct medication. And antifibrinolytics have been proven to be the most helpful in the trauma setting. TXA or tranexamic acid is an antifibrinolytic, and it's used for clot stabilization. And studies have shown that the early administration of TXA has actually led to decreased death due to bleeding, especially if it's been given within the first 3 hours post-injury. And the risk of, or the benefits of giving TXA early on outweighs the risks. It's been shown that patients that have received TXA early on in their admission have not had increased thromboembolic events compared to the patients that did not receive it. And so the benefits there are clear. What is unclear, though, is the use of other adjuncts. So protein complex, prothrombin concentration, PCC, there's an unclear role for that in the setting of trauma. It does lend itself to be more useful if the patient takes anticoagulation medications and there's a need for reversal. And so in that scenario, it may be beneficial to give the PCC. However, as a universal treatment, it's not currently recommended. And the same thing for recombinant activated factor 7. There's also an unclear role in trauma and hemorrhage control. It's been shown that potentially it has the benefit of decreasing the total volume of blood products given. However, there was no difference in mortality and overall outcome between the patients that did and didn't receive this adjunct medication. So for now, I would say the only thing that's really been supported by literature would be to use TXA early on. All right, and then as far as monitoring goes, hopefully on their initial presentation along with the other labs that were obtained, a TEG would have been obtained as well. And a TEG, or thromboelastography, is a viscoelastic assay that can provide real-time data that can help guide blood transfusions and component therapy as well as adjunct therapy. It may not be quite as useful in the initial stages of massive transfusion, but this can help guide transfusion later on because it allows the clinicians to be able to assess all phases of coagulation from clot formation to clot lysis and helps us be able to distinguish what type of coagulopathy we're dealing with, whether it be because of depletion versus a hyperfibrinolytic picture. All of that information can be gleaned off of a TEG, and then it helps us determine later on what specific components are needed, and we can adjust from that ratio-based transfusion model onto a lab-guided strategy. And currently, there are studies that are looking at whether massive transfusion that is guided by viscoelastic assay would be superior compared to a fixed ratio protocol. And the reason why this is being investigated is we know that massive transfusion as an intervention does not come without risks. And so if we can help with reducing excessive transfusions, potentially this is going to be the future of massive transfusions. But so far, tests or studies are still investigating this concept, so no real recommendations as of yet. All right, and then lastly, we need to know when to stop a massive transfusion protocol. In the initial presentation of the patient, obviously we want to be able to deliver those products and be able to stabilize the patient, but at some point it needs to be stopped and the patient needs to be reevaluated. The protocol itself in massive transfusion is a very resource-intensive process, and so if we can conserve those resources and be able to switch to a guided therapy, then that would be the goal. And so how do you decide when to stop? That would be looking at these 3 broad categories, and this is all recommended by the ACS. If there is anatomic control now of bleeding, and that usually means that surgery or embolization has been completed, then we can go ahead and stop. If there has been physiologic improvement and it's sustained in hemodynamic status, that could also be a trigger for termination. And then finally, and unfortunately, if clinicians have determined that further resuscitation attempts would be futile, then that would also be an indication for termination of the protocol. And so once the decision has been made to stop the massive transfusion protocol, lab and blood bank in particular need to be notified, so that way they can stop sending those cooler packs, and we can start dispersing some of those resources, and then transition to the school-directed therapy. And largely this is going to be based on labs that are obtained serially, and so we'll be looking at hemoglobin, platelets, PT, PTT, fibrinogen, and TEG, and those are going to be what's used to drive the next decisions for whether transfusion needs to be continued. And then concurrently, while the transfusion is occurring, we should have been working on correcting any other abnormalities, and if this was not corrected or if not optimized, we can continue to do that after the protocol has been discontinued, and that involves correcting any acidosis and then also looking at electrolytes, because these patients are prone to, especially to hypocalcemia and hyperkalemia, and those should be corrected. And then upon termination, as I mentioned earlier, massive transfusion in general doesn't come without its own risks. And so these patients should be monitored very closely for any development of possible complications after that transfusion has taken place. And that involves looking at things like ongoing bleeding and coagulopathy and the need for correction of that, any thrombotic complications that have since developed, if there's any suspicion for ARDS, looking for any transfusion-related reactions like hemolytic transfusion reactions, TACO, trolley, and then in some cases death, because even if the patient has survived the initial resuscitation, does not necessarily mean that they will be able to make it out of that hospital, unfortunately. All right, so that was a lot of information to cover in 30 minutes. And so if anything at all, these are the points that I'd like for everyone to get out of this talk. And so in the trauma setting, and when considering massive transfusion, most important thing is being able to identify the patients that are going to need the transfusion and would benefit the most from it. And once we make that decision and identify those patients, then we need to initiate that massive transfusion protocol immediately to decrease time to transfusion, ensuring that balanced transfusion to prevent that worsening of that coagulopathy, and then finally knowing when it's appropriate to terminate and transition to goal-directed therapy. And that's all I have.
Okay, thank you so much, Dr. Mirabati. That was for taking us through all the aspects of massive transfusion protocols. That was excellent. Next up, we have Dr. Rossi, who will be speaking on peri-anesthesia emergencies, anaphylaxis, and local anesthesia systemic toxicity. Dr. Rossi is currently an associate member at St. Jude's Children's Research Hospital, and he serves as one of the 3 clinical directors who oversees the operations in the Division of Anesthesiology. He holds an appointment as Associate Professor of Anesthesiology at the University of Tennessee Health Science Center School of Medicine in Memphis, Tennessee. He graduated from Des Moines University and completed his residency training in pediatrics at Monmouth Medical Center. Please join me in welcoming Dr. Rossi.
Good afternoon. I thank you for presenting the abbreviated version of my education and training. We could have been here for a long time. Anyhow, thank you very much for having me. And Dr. Raymond and I are separated by a short piece of I-40, actually, in our daily work. So there are no conflicts of interest to disclose. The learning objections are understand the pathophysiologic mechanisms of hypersensitivity reactions, be familiar with the classification of hypersensitivity reactions and the therapeutic interventions for hypersensitivity, and also understand the pathophysiologic mechanism of local anesthesia, systemic toxicity, and therapeutic interventions. Anaphylaxis is rapidly evolving, acute, potentially life-threatening, and occurs on contact with a trigger. Terminology that we utilize or that's evolved are non-allergic, immediate IgE mediated generally, delayed T-cell specific, and these terms not only describe the speed of onset, but also the likely mechanism. Other definitions have been proposed to describe anaphylaxis, either allergic, or which is IgE mediated, or non-IgE mediated. The descriptor anaphylactoid has fallen out of utilization, especially amongst the European societies. So when we look at this slide that describes the mechanism, one of the things I would like to point out is the non-allergic or non-dependent on prior exposure is the mechanism for neuromuscular blockers, right? Many of the neuromuscular blockers are very common trigger of a hypersensitivity reaction, but most of our patients have never had an exposure to a neuromuscular blocker, and that's and the precise mechanism for neuromuscular blocker hypersensitivity is not well known. Alternative mechanisms, non-specific, calcium and phosphase, the mass-related, non-allergic, and respiratory symptoms and these are all relate to specific medications. Mastocytosis is in refers to an abnormal tissue increase in mast cells. Cutaneous mastocytosis is most frequent, and occurs in childhood. Systemic mastocytosis occurs in adults, does not resolve spontaneously, and it usually includes histamine-releasing drugs or mechanical factors. I don't know if, I'm sure we're all familiar with the tourniquet being placed on a patient or a blood pressure cuff where you see a red stigmata that persists for quite a while. There is no evidence showing a higher prevalence of either non-allergic or immediate when compared to the general population. The clinical presentation perioperative usually occurs within minutes of induction. The presumptive diagnosis is based on clinical signs and their severity, and non-intravascular route of administration, not an IV bolus of a drug, but things like injection of methylene blue during sentinel node biopsy are all could be involved. How do we grade or classify hypersensitivity reactions? It's the Ring and Mesmer scale. The first two are relatively mild. 3 is where most of the serious anaphylactic reactions that require intervention reside, and then the fourth one is cardiac arrest. Grade 3 reactions are a cardiovascular compromise with systemic vasodilation and hypovolemia, cardiovascular collapse, tachycardia, and cutaneous features. Swelling of the eyelids, lips, and tongues may also be associated. Tachycardia may evolve into bradycardia or rhythm disturbances. Bradycardia may be the presenting feature also, and also it may present as essentially the Beazle-Garish type of reaction. This is also, there are manifestations that have to do with the systemic nervous system, sweating, goosebumps, piloerector reactions, and so forth. Bronchospasm is also associated with the grade 3 reaction. And as patients who are asthmatic, who have an anaphylactic type reaction, are more difficult to control. Cardiovascular collapse may evolve into circulatory arrest if not treated in a most timely fashion, and the diagnosis of anaphylaxis should be considered in any time there's unexplained perioperative hypotension, especially if the usual vasopressor therapy has had a suboptimal effect. Grade 4, as we said, is circulatory arrest, and this is the acute presentation. Usually presents as pulseless electrical activity and is probably caused by profound hypovolemia. What do we do in general? Well, if we're digging a hole for ourselves, number one thing we do is stop digging, right? So cease and desist with the presumed offending agent. Lighten or even discontinue the depth of anesthesia while resuscitation efforts are ongoing. The Trendelenburg position may be useful depending on the clinical setting to help restore volume in the cardiothoracic system and call for help early. That's also very important, and that's the common thread of many of these emergency situations. Therapeutic measures: liberal administration of intravascular fluids, epinephrine titrated to effect, and that's a very important point, that the epinephrine needs to be titrated to effect. It's not innocuous, right? We don't just keep slamming it in. We have to look, and there's been a great deal of research into and study of what are the appropriate doses. The various professional societies have their own recommendations on that. And support of the airway with 100% oxygen. Airway management. In the case of anaphylaxis with after neuromuscular blockers, it's pretty obvious: control the airway, intubate the patient. When it occurs during regional anesthesia or after antibiotics, the best approach is to provide oxygen by face mask and manage the reaction as the clinical situation dictates. In the event of loss of consciousness, control the airway. Volume resuscitation: large volumes of IV fluids infused immediately, and this compensates for peripheral vasodilation. About 73%, or studies estimate that approximately 73% of blood volume may extravasate into the interstitial space within 15 minutes of onset. And there's all this crystalloid versus colloid debate or controversy has been ongoing in many contexts for a long time. Most of the recommendations are for crystalloid. Colloids have been suggested by some of the national societies as a second-line agent. Recent consensus recommends, though, crystalloid be repeated where clinical response is inadequate, and the exact volume remains unknown, but continue until hemodynamic stability is restored. Epinephrine. The priority and the target of administration of epinephrine is to restore a mean arterial pressure, which maintains coronary and cerebral perfusion. There are different estimates, but the number 60 for a mean arterial pressure has been given. Maintain and restore cardiac output, and counteract the hypovolemic and vasodilatory components. Fluid resuscitation and epinephrine are first-line therapy. There's no contraindication to epinephrine, but as we said, it must be titrated according to the severity of the reaction. And epinephrine can be administered peripherally or in a continuous infusion. There are societies that have basically their own initial bolus dose in the range of 50 to even 200 with formulas to get that. And the Royal College of Anaesthetists of the United Kingdom recommend cardiopulmonary resuscitation if the systolic blood pressure is less than 50, even if there's not cardiac arrest. Again, this is a deviation from the usual ACS protocol, and that's not a US recommendation, but it's out there and there's a good deal of evidence and study behind it. Some clinical pearls: when cutaneous signs are initially lacking, that's often because there's not sufficient cardiac output, and when there is a paradoxical bradycardia associated, the atropine should be avoided. And grade 4 often presents as PEA. Atropine is no longer recommended in this setting, and the recommendation is for epinephrine. So other agents. In the case of rocuronium-induced neuromuscular blockade, there had been proposals to use sugammadex to bind to the rocuronium, but that's not borne out in subsequent literature. And the study where that was, or the case report in which that was manifested, the patient was simultaneously receiving vigorous resuscitation with fluids and epinephrine also. So it's difficult to say that that particular case report points to sugammadex as a solution. And in subsequent case series, sugammadex did not modify the course of anaphylaxis, and it may, in fact, independently trigger IgE-mediated response. As far as antihistamines and steroids are concerned, there's no evidence for the use of antihistamines or both antihistamines or steroids for the treatment of the hemodynamic disturbances. Antihistamines are useful for cutaneous manifestations for the symptomatic treatment, and we'll see steroids are indicated for treatments of respiratory symptoms, for bronchospasm specifically. Bronchospasm is addressed with steroids and short-acting beta-2 selective agents. The epinephrine, which administered for the cardiovascular instability, is helpful also for bronchoconstriction. The refractory anaphylactic hypotension, we have several considerations, but it will usually come to vasopressors, and the vasopressor of choice is norepinephrine. That's usually given after we've administered sufficient epinephrine and fluids. Arginine is a rescue therapy in pre-hospital settings, and doses are there recommended. Glucagon for patients who are on beta blockers who are hemodynamically unstable is also worth consideration. This is the cognitive aid for anaphylaxis. This is something we have in our operating rooms. This is taken from the Society of Pediatric Anesthesia Wake Up Safe PD Crisis set, and these are the recommendations that they utilize. I apologize for my pronunciation, but Takotsubo syndrome is left ventricular dysfunction, systolic dysfunction, but it can either occur with systemic catecholamines like a pheochromocytoma, or with administration of large quantities of epinephrine. If we administer a good deal of epinephrine, it may be helpful to get an echocardiogram and an echocardiogram and measure troponin. And also, these resuscitations are for the long term, and we should consider ECMO as an endpoint. If it's anaphylaxis, not responsive to treatments, it might go to that extent where mechanical support would be indicated. Okay, outcome. Well, the key question is the first point: proceed or abandon surgery. And there are no definitive criteria, so that it's usually administered on a case-by-case basis. The number one thing is the urgency of the surgery versus the degree of physiologic insult that happened in the reaction. Biphasic anaphylaxis is the recurrent anaphylactic. There's no recurrence in the NAP6. And morbidity and mortality, overdosing of epinephrine, as we pointed out, might be deleterious with pulmonary edema, ventricular dysrhythmias, myocardial ischemia. The other side of that is late or delayed administration of epinephrine in an anaphylactic situation is very often fatal. So it points out the need to carefully titrate doses, and this is stuff we all know and do all the time, right? Titrate to effect is our national motto in anesthesiology, and vigilant monitoring, but especially in these cases. And in the United Kingdom, they routinely utilize anesthetic allergy clinics. So we don't have one in my institution. If referral is warranted, we refer on a case-by-case basis. But other countries, especially where there's a national health system or a national health service, do have a structured follow-up for interoperative anesthetics. These other issues I'm going to skip over only because local anesthetic systemic toxicity is also going to take a good deal of time, and I apologize. So as we know, LAST is a life-threatening adverse event associated with the more and more prevalent utilization of regional anesthesia and local anesthetics. It's estimated to be 0.3 to 0.27 episodes per 1,000 peripheral nerve blocks. That's not all local anesthetic utilization, that's specifically peripheral nerve blocks. That's probably an underestimation. The techniques that are evolving, especially high volume fascial plane blocks, continuous catheter techniques, multiple local anesthetic techniques in the same patient. We've seen, our anesthesiologists who are adept at doing blocks might do more than one block, especially when they're doing tap blocks or something like that. They might have several of them. So that, as you do more blocks and more catheters, there's more local anesthetics. So that points up the need to be really, really mindful of what the total dose you're infusing is. The other thing is the use of tumescent anesthesia. So the pharmacokinetics, the peak plasma concentration, and the time to systemic is governed by the rate of systemic absorption, the vascular supply to the injection site, mass of the drug deposited. So it is, in fact, the dose of drug that is important. Once in the plasma, the local anesthetic, the disposition is determined by perfusion. Well-perfused organs get the mass of the local anesthetic. The free portion, it's the free portion of the drug that determines the clinical and toxic effects, and that's why it's important to realize the alpha acid glycoprotein concentration that individuals have. One of the things that we really need to keep in mind is that fourth point there, the mitochondrial metabolism inhibited by the local anesthetics, and that can sort of slow us down or inhibit our resuscitative efforts. So it compromises cortical inhibitory pathways by blockade of sodium channels. And that kind of, the classic teaching was there was a prodrome of sort of minor CNS effects. You know, patient feels strange, reports feeling strange, might have the circumoral paresthesias or change in taste that leads to then more serious central nervous system manifestations, which could culminate in a seizure, and then to cardiovascular effects. It's becoming more and more evident that you don't necessarily have to go stepwise through the prodrome. So which means if somebody's having what might seem to be minor manifestations of local anesthetic toxicity, you really need to be very forthright and aggressive in your thoughts about treating it. Okay, so cardiovascular toxicity is manifest by conduction disturbance, myocardial dysfunction, and rhythm disturbances. We have sodium and calcium channel exchange pump blockade, and CNS toxicity is the most common feature. It could be seizures, perioral paresthesia, confusion, audiovisual disturbances, the metallic taste in the mouth, agitation. Risk factors can be those related to the drug, the patient, and the technique. I'm going to just go here. Patient factors, age, and the thing to remember here are extremes of age and pregnancy. We heard pretty extensively about pregnancy and the engorgement of the epidural space, but that's, local anesthetic systemic toxicity is something to keep in mind in that context. Renal disease, cardiac disease, hepatic dysfunction. And it differs between block types. The infiltration techniques, one thing to point out are neuraxial are at a higher risk, fascial plane blocks, and liposomal bupivacaine. Another important point, a fifth of cases of LAST occur outside the traditional hospital setting, and half happen in the hands of non-anesthesiologists. And so why is that important? My contention would be that an anesthesiologist is more likely to have the situational awareness of what might be ongoing. Prevention, we say in many circumstances it's easier to prevent than to treat. There's no single element. However, ultrasound-guided nerve blocks significantly reduce the incidence of LAST. The numbers might be slightly different than the 60 to 65% cited. Restricting the dose is very important. And then simple things in patient safety, labeling the syringe and meticulous handling. So management of patients receiving injections of local anesthetic should include standard monitors. Monitoring should go on for 30 minutes after the completion of injection, and immediate access to the cognitive aids or checklists in an anesthetizing location where local anesthetic is injected is very important. And some people utilize this the term a last box, like where you have your intralipid and the cognitive aids checklist immediately available. We in our institution have the intralipid is in an Omnicell in the core of the OR, but the important thing is it should be immediately available in every locale where local anesthetics are injected. The other place where it's very important for intralipid to be available is any place we're doing continuous infusions. So that means, for example, if we're doing an epidural infusion or a peripheral nerve block catheter infusion, the way we've addressed that issue is it's contained in the order set. So you have the intralipid in the electronic management system, or you can't order the local anesthetic without ordering the intralipid. And that I'm not advocating that that's ideal. Preparation and treatment, airway management, early administration of intralipids, and intralipids may improve the cardiac output. And these are the two principal cognitive aids or checklists. The one that we're seeing now is from the Society of Pediatric Anesthesia, and this is from the American Society of Regional Anesthesia. All right, we don't need to belabor all the references. I'm sorry, I was a little awkward trying to squeeze all this stuff into my limited time. Thank you very much.
Thank you so much. Excellent talk. Lots of good information here today. Now we're going to begin our panel discussion. So if you have a question for one of our speakers, please feel free to utilize one of the microphones that are available to you. I want to start off by asking Dr. Raymond about amniotic fluid embolisms, and you mentioned possibly using intralipid, and I wasn't sure if there was a proposed mechanism for that, or is it also just that you're usually running epidurals in these patients, and you're also just trying to remove local anesthetic toxicity, as we just went over, as a possible concomitant factor in these patients?
Great question. So the thought about using the intralipid was actually a sink mechanism, very similar to absorbing local anesthetics. So rather than them thinking, oh, it's potentially confounded with blast from the epidural, it's actually a direct mechanism of absorbing that amniotic fluid, preventing it from contributing to that anaphylactoid sort of cascade.
And this is something that's usually readily available on the floor, since we're already running the epidurals. Yeah. And so would this be something you would advocate that we administer along with some of those other medications that you address, since low risk,
I certainly see no downside to it.
That's the other thing. In my reading for this presentation, there is minimal downside to administering intralipid, and that's why the thought is, as soon as it becomes at all included in your differential diagnosis, you should really give very serious thought to giving it, because it's often life-saving and very, very infrequently deleterious.
To your point, I had a question for you about, you mentioned kind of the access for intralipid at your institution, where its location is kept. That's kind of a usual consideration when we think about intralipid. And I know even in our own institutions we've had issues with this, but I think your idea of actually having a standard order for that can help improve access to this medication in an emergency setting, because if there's an order, presumably you use a lot of health record systems that pair with our medication delivery systems, and if that order is there, then a nurse can easily pull the medication without having to search for it.
So one of the manners in which we administer local anesthetics is not just an epidural or a peripheral nerve block or something of those nature. We have a big chronic pain service at our institution, and probably one of the biggest components of that are patients with sickle cell disease. And we're using more and more lidocaine infusions on patients with sickle cell disease. So when you order the infusion, and you order the infusion, you automatically get the order for the intralipid. We've also tried to educate the floor nursing staff
to be very aware of that now, and which is fantastic. The only thing is, when they're getting aware and their index of suspicion is high at 3 a.m. and you're the on-call individual covering that, it can be a little bit inconvenient. We've seen some symptoms on the floor that usually resolve with discontinuing the. But that and as we come up with more creative therapeutic approaches to managing pain, we're going to have to also, I believe, be prepared to handle possible collateral effects.
No, you can keep that.
Okay.
Would you advocate also putting it in certain carts on certain floors?
We've had problems with carts, and this is specific to our institution, with medications outdating in the carts, and that, you know what I mean? And somebody scrambling around before a mock JACO exercise or before they're really coming. So what we've done is put them in the locales in which we're likely to do injections or nerve blocks. We have a procedure room where we sometimes do nerve blocks, and the operating room's the most obvious place. So it's in an Omnicell, but the situational awareness is the most important thing. If you're doing a block, know where it is, and everybody should know where it is. The anesthesiologist should be the leader in knowing about stuff. The nurses always know where it is, or at least in our institution, but you really have to communicate among the various team members to just know where. But I think without a doubt, it needs to be immediate. The words "immediately available" are often interpreted differently among different people, but it really has to be right there when you're doing the injection, I believe.
Absolutely. I think we have a question here.
Couple questions. So you say never do a spinal after an epidural has failed. Is that correct?
Correct. If you top up the epidural with significant amount of volume, let's say you're taking it back to a C-section and you put 20 cc's of your lidocaine, you should never consider doing a full dose spinal after that. I have had colleagues who will maybe reduce it to like a third of a spinal or do like a DPE, but a full dose spinal certainly is contraindicated.
And I was like, you were in our office the other day because we were having this discussion exactly of that, and they were CRNAs would say, well, do we do a third or a half, or do we? So something to bring back. Another question I have is about the ERAS protocol, which uses a continuous lidocaine infusion. I've always questioned because our protocol involves continuing the lidocaine through the recovery room. Once they're going to leave the recovery room, that's when they discontinue the lidocaine infusion. Is there any? I haven't read anything about any last problems with that, but I wonder about if there should be an interlipid.
Are you referring to a block or an epidural, or to?
No, it's an IV infusion along with the magnesium and all
for
that.
sickle cell patients, we usually time limit it. We'll say we're going to give Johnny an 8-hour infusion, and then he's going to be off it for a period of time and see how he responds to it, and then do it over again.
Oh, the way our protocol said it started at the beginning of induction, runs through to when they fully recovered through recovery room. They turn it off in recovery room, and then they send them to the floor.
Mm-hmm.
So the downside to that, so perioperative medicine is also one of my favorite things, and we typically run our lidocaine infusions at least 24 hours, sometimes 48. And if you look at the pharmacokinetics of it, in terms of the concentration of the lidocaine levels in your blood, it actually kind of plateaus off at a significant, I can't remember what it is, but significantly below what would be the systemic toxicity level. It plateaus below that, even several days of an infusion. But the downside to stopping it in the recovery room is because of like that second hit phenomenon where patients, as they start to mobilize on the floor and start engaging in physical therapy and that sort of thing, the benefit of the lidocaine infusion is it's anti-inflammatory. And so it prevents that sort of inflammatory response as they start to get up and mobilize and participate in like what you would call like the standard things that you need to go home, right? And so that's why we typically run it for a lot longer. And I think the downside to stopping it so early is it doesn't account for that second hit as they start to mobilize.
I think part of the protocol I'm not on the PT committee, so I don't get to say, I just live with the rules. Is that the fact that the nurses on the floor were uncomfortable with the lidocaine infusion. So I think that's why they
Yes.
cut it off.
It took
That's
at
what I
least
can
6 months of us fighting
Yeah, and that's-
with nursing to do it.
Usually the nurses for us are specific to hematology, so they it takes, they get used to it quicker, you know. But part of the reason to having a time-limited infusion is, in fact, to get nursing buy-in, you know.
I had a question for Dr. Maravati about, you mentioned high ratio transfusions, improving morbidity and mortality. Is there any evidence that you've seen that promotes the use of whole blood transfusions versus kind of giving each element of the transfusion kind of piecemeal as we're doing?
Yeah, so the use of whole blood as a transfusion strategy rather than component-based therapy has definitely been investigated. But I don't know that we've quite gotten to the point where that would replace the current recommendations. They've definitely shown some benefits to it because, again, it mimics what the patient is losing, but there are certain limitations to it, like how would you store this product? How long can it be kept? Is this something that can be as available as those emergency release components? And so there's just a lot that still needs to be worked out before we could even make it towards using that as a recommended therapy versus what we know works. But I am no expert in whole blood therapy, so I can't say what direction we're going in with that.
You also mentioned the CRASH 2 study, which showed some mortality and morbidity and benefit from giving patients TXA early in their course. Have you, or does your institution have any sort of program where they implement giving this drug early in their course, whether like en route to a trauma center or down in the trauma bay, or is this typically something that we give in the operating room, and are there ways to kind of escalate earlier administration of this medication?
As far as early administration of TXA goes, at least in my experience, this is something that we would institute if the patient ends up going to the operating room or if we are involved in their resuscitation in the emergency department. This would be a decision that's made jointly with the trauma team who's actively managing that trauma. But if we end up bringing a patient to the OR and we're recognizing that there is ongoing bleeding and we're still in the early phases, and we recognize that massive transfusion is going to be a part of this patient's therapy, then we would actually initiate that transfusion. And I can definitely recall a couple of major surgeries where we did end up using TXA, and it did help with controlling bleeding alongside all the other things that we did with massive transfusion. And it helped. It made a difference.
Is it a one-time bolus you're giving, or are you giving a bolus and then instituting an infusion?
The recommendation is a one-time bolus of the TXA within that first 3 hours. There's actually, in the CRASH 2 trial, they also discuss that the utility of giving it after that first 3 hours actually may not be quite as evident, and some patients have actually experienced increased mortality if it's delayed. And so if you're going to give it early, and give it if there's an indication for it based on TEG.
Have a clinical trial in progress using PXA in limb-sparing surgery for patients with sarcoma, and it's given, immediately pre-op. And I don't know all the results or anything like that, and we're not ready for publication. So, but it seems it didn't get terminated after the first year or two. So, and we have a good deal of patients. So.
For Dr. Raymond, I have another question. So in dealing with obstetric emergencies, since the conditions are sometimes somewhat unique, have you found, in your practice that kind of practicing or coordinating with other members of, the L&D floor has helped improve our ability to minimize confusion when these situations arrive, and know where, important items that we need are, has that kind of helped improve like patient care?
Absolutely. So we have established a multidisciplinary simulation team where we partner with nursing, obstetrics, and anesthesia to all put together in situ low fidelity simulation. I believe actually doing once yearly multidisciplinary simulation is now going to be a requirement with JCO. At least that's what word on the street was. So I definitely have seen a improvement since we started doing that. So for example, that was our way to introduce our postpartum hemorrhage checklist. And I love now when I show up to a postpartum hemorrhage and there's an L&D nurse who feels empowered to say, where's the checklist? Because they went through that training with us. So absolutely. I will put in a plug for the Stanford Emergency Manual. Are you all familiar with the little red Stanford Emergency Manual? They recently came out with one specific for obstetrics. It is free. You can go online and download it, or I believe there's also an app. So for those who don't practice OB regularly, maybe take call occasionally with it, that is a great manual to not only have for yourself, but recommend for trainees as well.
I believe they'll actually help you to create your own for your specific context or situation.
Oh, great.
Wonderful. I believe we have another question.
I have a question about postpartum hemorrhage associated with atony.
Mm-hmm.
We go through the normal uterotonics and all the subladders, but I've read studies that using calcium can help. But every time I mention this to anybody else, they look like I'm speaking something gibberish.
No, you were right. You were so right. I always give a gram of calcium in a postpartum hemorrhage. Always.
Okay. And then as far as the last goes, I work a lot of my time in a private pain office, and we do not have ventricular lipid available there, but the volumes we use of local anesthetic are relatively small compared to the anesthesia world. Are you aware of any guidelines or any recommendations for having ventricular lipid in the outpatient setting, in the pain center?
And not because everything we do at our hospital is kind of physically affixed to the mothership, so to speak. So even if we're going to do something in the clinic, it's part of the hospital. Then we would actually, if we were going to do a block in the outpatient setting, we would order the lipid to be there, at very least in the bag. Is that better? So we would at least have it in the physical setting of the block of the injection.
But that's more for an anesthesia block as opposed to a pain injection.
Yes.
Okay. And then just to piggyback on another topic we talked about earlier, our hospital has started using whole blood for OB as well as trauma service, and it's part of our massive transfusion protocol. And we just started using this, but it's for you can click on that when you order the protocol, and you'll get the 2 units of whole blood immediately. And that helps a lot with, particularly in OB, with getting the factors from the thawing of the plasma. So I don't know what the results of that are, but we're trying to use that.
So the expression always was fresh whole blood. How fresh is your whole blood?
Yeah, we just started. But we usually have 2 units available that we would have the option to give immediately. Part of the transfusion protocol.
I'm just curious as far as like if there is an ongoing need, so if you're to continue that massive transfusion with whole blood, is it delivered in the 2 components at a time kind of
So
manner
I
then?
believe the way it stands currently is we get the 2 units of the whole blood as the first shipment, and then the rest, 1-1-1 is our goal later.
Oh, okay, so that's for the initial resuscitation is
Correct,
with whole blood,
exactly.
and then transition to component therapy.
Correct, exactly.
Oh, okay.
But for when you want the 1-1-1, it always seems like there's not enough platelets or there's not enough plasma, or the plasma takes time to thaw, and the whole blood theoretically would be able to start that process while you get your component therapy online.
I think we have another question.
This question's for Dr. Miravite. One of the things that we've used pretty religiously for decades now is ABG to drive intraoperative large volumes of blood loss that require resuscitation, to drive different metabolic strategies, as well as looking at electrolytes and and hemoglobin levels, etc. Do you think that getting a TEG as something that we use more often within the perioperative field outside of trauma, so big cases that require TEG outside of maybe transplant, which I think it's used more frequently in anyway, will become en vogue in the future, given that people are starting to look back at it and say, maybe this has more outcomes and product-driven information than we previously felt was needed when we have an ABG to help us?
I think that it's definitely something to consider because, like you said, it garners a lot more information than just our standard labs. Even an intraop ABG is limited as to what information it can report, and while you can draw coagulation panels, the conventional assays don't give you real-time information. It takes time for that to come back. So by the time that your results are back from an hour ago, like you may be dealing with a totally different clinical picture. And so using TEG and getting that real-time data is actually going to be much more useful. And I'm not recommending using it with every single case, but especially in cases where you think that bleeding could be an ongoing issue and it could be something that you'll be dealing with for the entirety of the case, like spines, major orthopedic procedures, certainly traumas, but like major abdominal surgeries. Having the option to use TEG and using that data to drive the transfusion is going to be, I think, really important and something that we should be doing. And not just limiting our ability to transfuse based on the hemoglobin, but also addressing those other possible causes of bleeding.
Thanks. I have another question for Dr. Rossi and Dr. Raymond also. So I attended a lecture years ago that made me feel like intralipid is an untapped resource for many different strategies within the OR, and it claimed that it was the antidote. So if somebody had cocaine intoxication, methamphetamine intoxication, tricyclic antidepressants, those types, that it could actually help with reversal and binding of those agents as well. And given that one bag of intralipid is less than $10 acquisition, it sounds like, even from how you've been describing its use in those other arenas, that it may be something that requires further investigation so it can become a valuable tool.
I would agree with that. There was some mention in the reading that I did that part of last is the mitochondrial dysfunction in the organs, that it does help overcome that, but that's not evidence. That's just like a gut impression based on reading a bunch of stuff. That's certainly not evidence based, but it's there.
Thank you.
Thank you, everyone. If there are no other questions, I would like you to join me in thanking our panel for the third session. Our speakers, they did a phenomenal job. We really appreciate their expertise on these topics. Being prepared in these situations is vital, and so hopefully the information that they've provided you today you can take home with you and help in your preparedness. That concludes the program for today. It was a wonderful start to the program. Please join us again tomorrow for more sessions, more great speakers, more that this college has to offer. If you signed up for a PBLD, please join us in the Regency room tomorrow, and that will begin at 7. Thank you very much, everyone.
Thank you.
Thank you, guys.